Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Dr. Jon Barlow at the Mayo Clinic in Minnesota. John, how you doing?
Great. Glad to be here.
Me too. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, the Mayo Clinic, or the institutions of any of our guests. So we are sitting here today in Zurich, Switzerland with Dr. Markus Scheibel at the Schultes Clinic, and we've been very fortunate to be his guest over the past 48 hours. We've seen him in the operating room and in clinic. He's been a very gracious host, and we've learned a ton from him. So thank you so much for having us, Dr. Scheibel.
Thank you guys for joining us.
So we've learned a lot from you in the past 2 days. I think one of the things that's been the most remarkable is we've seen you really leverage your shoulder arthroplasty registry. So I wanted you to talk a little bit about the registry and some of the things you've taught us that you've learned from it recently.
Yeah, that's a great question. So, our arthroplasty registry was initiated in 2006, and it's actually our oldest registry. We're also running 3 other registry, but the arthroplasty registry is probably the registry with the longest tradition within the hospital, and obviously it's instrument of quality control, number one, but number two, also a great tool to conduct research. And we have included now more than 3,500 arthroplasties over the last 17 years. So it's filled with data, and usually we see the patient, of course, preoperatively and then on a regular basis postoperatively, usually at 6 months, 2 years, 5 years, and 10 years and 15 years. So the idea is really to have long-term data out of this registry. And the beauty of the registry and the beauty of the environment here is basically that we have surgeons using different implants. So we can compare the performance of different implants according to the same pathology. And I think that's really a great thing due to the situation. As you know, there are so many companies out there bringing different implants to market, and sometimes customers are confused which implant should you use and what is the best performance and so on and so on. Number two, I have to say, we learned also from the registry, if an implant doesn't work properly, the registry can help you in identifying the problem of the implant, and also look at your revision rate, look at the loosening or whatsoever. So there are different, true advantages. It's not just about quality control, it's also about research. And most of the studies that we have been published over the last couple of years on arthroplasty, and those that we will publish in the future, they originate from registry data.
The other thing that I would say is we've traveled across Europe, we've seen some different strategies in terms of component positioning and type. And one of the things that I really appreciate is you've, from a research perspective, been thoughtful and being systematic about how you're putting in reverses so that you can later study it. What's your current strategy in terms of lateralization, distalization on the glenoid side, on the humeral side, and how do you customize that for patients?
Yeah, that's also a great question. I think, the answer comes from registry data. And one of the first studies that we conducted a couple of years ago wanted to compare the Grammont type of design with a lateralized design. So this was a 155-degree neck shaft angle with an eccentric sphere, and we compared it to 135-degree and a lateralized sphere design. And truly, this study showed that overall, let's say, scoring is pretty comparable, but there's a true advantage for the lateralized design in terms of external rotation, in terms of decreasing notching. So from that study on we evaluated what is better: onlay designs, inlay designs. Do you have to do just base plate lateralization, or even base plate plus sphere lateralization on the glenoid side? So we looked at another group of patients where we have been using an onlay system, 145-degree neck shaft angle, with we call it bipolar metallic lateralization. So it was just not just on the humeral side, but also on the glenoid side with a base plate and a sphere lateralizing the construct. And this has outperformed, all the results that we have seen so far. So at the moment, we are very much in favor of bipolar metallic lateralization. We truly believe that the greatest effect comes from the glenoid lateralization overall, plus obviously the humeral 145 degree neck shaft angle. I cannot give you true numbers. I cannot say you have to lateralize 5 millimeters or 6 millimeters, because I don't really believe in this kind of calculation. I rather believe in operating patients with the same pathology, with the same kind of component positioning and component lateralization, then look at the results of these patients and then come up with an idea what is the best configuration. And probably you can, do this kind of component positioning and component lateralization with different implants. It does not need to be one specific implant, it's just a question how you place it, right? So at the moment, as I said, we like to lateralize with metal via the base plate on the glenoid side, plus an eccentric sphere, and we like to have a 145 degree neck shaft angle on the humeral side. That's the current strategy.
Yeah, I think that's it's super interesting. I think for both of us to hear that you're so systematic about it, which I think is a really great way for us to advance. That you say we'll do this, determine how well it works, and then try and make incremental improvements instead of always altering what you're doing and then having a great deal of difficulty retrospectively determining which of those things worked and which one didn't. One of the things I wanted to ask you about the registry is, you mentioned that there's multiple components, multiple companies, and that you've kind of migrated towards this, what I think both John and I see is a little bit of a compromise solution. It's not 135, it's not 155, it's 145 in the middle. It's not 10 millimeters of lateralization, it's maybe somewhere around 6 millimeters of lateralization. Do you think that that's where everyone's moving? I think that's what we're seeing. Do you think that's kind of maybe this kind of, as of our current understanding, kind of optimized reverse? Is that somewhere in the middle solution?
Yeah, I think, if you take, let's say, the Maxim on the one side, the Grammont type of design where everyone started with, at least in Europe, and you on the other side, the 135 degree where you only lateralize and you don't really distalize anymore. So I think the truth lies somewhere in between. And I mean, you, from your experience that you have now had with the fellowship, and you've seen that most of these surgeons moving in this direction, it probably reflects also the experience of the surgeons they had looking at their patients, with these specific implants. And we're in Switzerland, so we always like to make the Swiss compromise. So that's why we are there, probably. Yeah.
That's great. I wanted to move on to something we haven't talked about as much, but that you've written a lot about, and I think taught a lot of surgeons about, and that's AC separations and kind of the optimum treatment of it. I know, reading the literature, it looks like you've been through a couple of different iterations. Tell us about your current treatment algorithm for those, and what you've kind of learned over time about how to optimize the treatment for that injury.
Yeah, that's also a great topic, and one of my favorite, since we've been doing so much scientific work on AC separation, acute and chronic. I have to say that over the last 15 years, we are operating on less patients with AC joint instability because, as you know, patients who have acute Rocco type 5, they can do very well with non-op treatment. And I think the strategy in the US is still you treat them non-op, and if it doesn't work, you go for reconstruction. However, I have to say that historically, and also the patients that we are seeing here, it's probably a specific patient selection, but those patients, often they don't want to have the cosmetic deformity. So they're not really patients who, they care about function, of course, but if they stand in front of the mirror and you ask them, listen, you want to stay like this for the rest of your life? Most of them will say no. So it tends to be a little bit of a cosmetical procedure, it's strange, but it's like this. And from the technique point of view, I can tell you that I started in 2006 with a tightrope device in a single tunnel procedure. This was actually the tightrope that was initially developed for syndesmosis repair. And we did like 5-6 cases, and they all had a redislocation very early at 6 weeks to 3 months. So we said this construct is not strong enough. So we went to a double tightrope reconstruction, and we published our results in HASM in 2011, which was a double button, let's say, coracoclavicular stabilization without addressing the AC joint.
Mm-hmm.
And from this study, we learned that around 50% have persistent posterior instability of the clavicle. And those patients had also inferior clinical outcome. So we thought, okay, if we do an arthroscopic stabilization, we need somehow address the AC joint as well. So just to take care of the horizontal instability component. So we added horizontal triangular cerclage that can be done percutaneously. I mean, all our videos are on WUMEDI if you're interested to watch. And we did a double tightrope plus fiber tape cerclage for almost 6 years. That was a very stable construct, and the results we had, they were very good in terms of function, also, but also of cosmesis. But I also realized that it's for surgeons who are not so familiar with the arthroscopic technique, making 2 tunnels, under image intensifier control plus arthroscopy, it's difficult, and obviously you weaken the bony structures, you weaken the coracoid, you weaken the clavicle if you make 2 drill holes. So I thought we need to simplify this operation, but still keeping the results or keeping the advantages of CC and AC stabilization, what we learned with the techniques that we would develop in the future. So we went back to let's say a single tightrope device with an horizontal still cerclage, so to treat CC and AC instability. But at the moment we are using the low profile tightrope because it's an implant that has, in my opinion, 3 advantages. Number 1, it's very stable. Number 2, it avoids knot stacks, so you're not tying on top of the clavicle. The knots are inside the top head button. So, and we published this already. There is less implant irritation with this implant. And number 3, which is I believe is something that is not really has not had the awareness yet. It decreases tunnel widening. So we realized that tunnel widening can be associated with instability of the clavicle after AC reconstruction. So our goal needs to be in the future to avoid tunnel widening, and the low profile tightrope, since it's part of the tightrope is in the clavicle, at least this portion is protected from tunnel widening. So we are now at a very, let's say, relatively simple technique that even my residents are doing in 20-25 minutes with very high stability. But, and that's my final point, we still have these, let's say, biological failures. So we have patients who have recurrent instability due to the fact that the ligaments do not heal. And so my strategy at the moment is I would like to figure out predictive factors in the acute situation where I still can do just a synthetic stabilization and I can predict that the ligaments heal. And what we're doing at the moment, we are doing MRI studies, pre-op MRI studies. We look at the tear pattern of the CC ligaments and of the AC ligaments, and we will correlate our results of the synthetic stabilization with a pre-op detected tear pattern to figure out if this will help us in counseling the patients better preoperatively if they need maybe a graft in the on the first operation already. So that's where we are at the moment. A long story, but 2006 no one was doing this arthroscopically. It was really a new way, and I remember the first operation took 2.5 hours, just for making 1 tunnel through the clavicle and the coracoid, and now the residents do this in 25 minutes. It improved a lot, I would say. And if you would compare, let's say, this procedure compared to what is out there, like hook plate and so on. Of course, the hook plate is probably stronger, and you can mobilize probably the patients earlier. This has been shown in some studies. But at the time when the tightrope patients are going back to activities, are going back to sports, you would readmit the patient with a hook plate to hospital and schedule him for surgery to remove the hook plate. So this kind of, let's say, very early advantage is not really reflected after a couple of months. So that's why I'm still doing the arthroscopic way of AC joint stabilization. And as we discussed already, we are using grafts more often, even in the acute setting at the moment.
Well, and we know that you're carefully following those patients, and you have a registry for your AC patients as well, non-operative and operative. So we'll certainly look forward to learning more about that. I'd like to switch gears. Another one of the really fun things of traveling around Europe is we get to hear the history of some of different shoulder procedures and the evolution of shoulder procedures. So let's switch gears to the bone block techniques. And you were able to share with us some insight about some of the history of stabilization procedures across Germany and Europe and Switzerland. And can you enlighten the listeners about some of that history, and then maybe where you are now with arthroscopic or open bone block versus Latarjet procedures?
Yeah, that's also one of my favorite topics, as you know. I just have to say, how you treat patients with anterior shoulder instability really depends also a little bit where you did grow up. So if you would did your residency in France, you would be a Latarjet guy for sure. If you would have done your residency in Austria with Herbert Resch, you would be a free bone block J-graft guy. So it really depends who teaches you. And in terms of indications, I mean, all know the NEO award study from Philip Moroder, where he showed no difference between free bone block versus Latarjet. So that just shows that both technique work, right? So that's just clear, both technique work. I always have the feeling, since I was doing both techniques for years now, that the Latarjet procedure has a higher rate of complications, even after the learning curve, I have to say, and the spectrum of complications with the Latarjet is different compared to free bone block procedures, and that's also reflected in the world literature, with permanent nerve lesions and something that we have never seen with free bone block procedures, and it's not published about this yet. So that's from my current thinking about bone block free bone grafts versus Latarjet. And I would say for the free bone blocks, we started in 2006 leveraging this operation to an arthroscopic procedure. So initially we designed a technique where we've been using biocompression screws after inserting the iliac crest via the rotator interval, and then we fixed it with biocompression screws. And the idea behind was always to avoid problems with metal in the glenohumeral joint, and we have seen many of those problems, in young patients where the screw heads were prominent and causing chondral lesions on the humeral side or damaging the subscap in the front. So there were multiple problems that we wanted to avoid with not just switching from open to arthroscopic in terms of subscapularis problems, but also changing the implants, and it's just nice if you look at the bony reconstruction in the front of the shoulder at the inferior glenoid, and there is no metal. It just looks good, right? And so at the moment we are still using free graft procedures arthroscopically. My favorite technique at the moment is to use interconnected corkscrews as a fixation method. It's very fast, it works very well. I just don't know what is the best graft. And I think there is a long discussion on allograft, autografts. We all know that the iliac crest is, in terms of the harvesting morbidity, probably not the best graft that you would use. It takes additional time to harvest the graft, and so on, with the associated complications that can occur. But at least we know from the iliac crest we have the most data available. So every new graft that comes out, like the distal tibia, fresh frozen distal tibia, like you're using in the US, the results needs to be judged according to the results of the Ilia crest. So and as a secondary operation, if the anterior approach with the corkscrews doesn't really work, we do the bone cerclage, which is a little bit more complicated but also very strong. It avoids metal, and the results we have, they're quite comparable to what we used before with the biocompression screws. One thing, and that's very interesting, you mentioned the history. So as you know, the first free bone block procedure was conducted by Eden and Hübinette. So Eden was a German surgeon. He was working at the University of Jena, which is mid-Germany. And he used a free bone graft at this time, I think in probably 100 years ago, around 100 years ago. And Hübinette, a guy from Sweden, also used a free bone block, and they somehow knew each other, and they decided to name this procedure Eden-Hübinette procedure. So that's how it developed. And so this was a German guy first, and it's interesting that actually the first labor repair, the Bankert repair, what we call it today, was not really done by Bankert. It was done by Pertis. Pertis, from the hip disease. Pertis was also a German surgeon. He became more famous for the hip disease that he discovered. But he, in his book in 1906, he described the first labor repair. So we should actually rename the Bankert repair and call it Pertis repair, if we are very true.
Mm-hmm.
And unfortunately, I have to say that the Lattaché procedure, obviously it was developed by Lattaché and then further modified by Gilles Walsh, Bristow in between, and so on with modifications. But unfortunately, and that's just the truth of the history, the first one in the literature who conducted coracoid transfer was a German surgeon. And his name is Nöske, so he was a German surgeon from Berlin. He didn't really do a coracoid osteotomy and then transferred the coracoid all the way down and fixed it with screws. He did kind of a tria procedure. So he osteotomized the coracoid and he tilted it down, and he used sutures to between the osteosutures, basically between the block and the glenoid, to get primary stability. So the three blockbusters that we are doing in nowadays have been invented by, I hate to say it, but I love to say it, German surgeons. Obviously modified by many other people and popularized by many other people. Yeah.
We were talking together that we feel like that just means the Germans need to better speak English so they can publish their results in English literature and get credit for them.
I agree. But we all improve over the years.
Well, thank you so much for speaking with us. This has been a phenomenal visit for both of us, and we really appreciate your insights and the time you've spent. We know you're busy, and it's been very impactful for the both of us. So we really appreciate it, and we're thankful for your time.
Thank you. Great for having you.